My name is Kelly Batley.
My name is Clay Thompson.
My name is Neil Mowney.
We are MRHFM, a national firm with 70 attorneys and 11 offices across the U.S.
At MRHFM, we exclusively help mesothelioma patients and their families. It's all we do.
This is why we are proud to sponsor the Mesothelioma Applied Research Foundation and its work to fund mesothelioma research and provide support services and education for patients and their families.
At Bristol Myers Squibb, we believe that a single touch has the power to transform, to help make every day better, fuller, happier, healthier. So we are always working, proving that innovation and compassion work best hand in hand, developing clinical trials that better reflect the communities we serve, ensuring that every breakthrough reaches those who count on them the most, striving to change the world, starting with a single life. Yours.
At Novacure, we strive to extend survival in some of the most aggressive forms of cancer through the development and commercialization of our innovative therapy called Tumor Treating Fields. Novacure is pleased to partner again with the Meso Foundation.
Hi, everybody. Welcome to this episode of MesoTV. I'm pleased to present Dr. Pingpank from UPMC, and I'm going to have him introduce himself right now and tell us who he is and where he's located and what his affiliation is.
Great. Thank you very much. My name is Jim Pingpank. I'm a surgical oncologist who has a clinical interest in regional therapies, especially the peritoneal cavity and liver. I'm at the University of Pittsburgh Medical Center in Pittsburgh, Pennsylvania, in a place that does a lot of regional therapy. And one of our areas of interest and hopefully expertise is that of primary peritoneal mesothelioma as part of a rather comprehensive thoracic and peritoneal mesothelioma program that includes both surgical and medical and now immunotherapy programs.
Wonderful. Well, thank you for coming on today. And first, I'm going to ask you just a couple of questions about peritoneal mesothelioma. It is one of the ones that I get many questions about. So what would you describe it as looking like when a patient comes to you and kind of asks you, because we do hear that it looks differently than some other primary abdominal cancers?
Most patients who come to us have relatively non-specific symptoms, and the most obvious one or the most frequent one is abdominal distension, usually associated with the fluid or ascites that patients have in their abdominal cavity. And depending on the length of time people have had it, we also see that it can be very insidious in its onset, and people attribute its symptoms to a variety of factors, including just gaining weight or not being active enough. And so some people, even though they've been gaining weight, have a lot of muscle wasting and loss of protein because they have, in fact, had a relatively progressive malignancy. There are a subset of patients, especially women, who undergo gynecologic procedures such as diagnostic laparoscopies for infertility, or people who have operations for hernias, who present very early and have absolutely no symptoms and no systemic signs of cancer, and have no weight loss or anything. So it really is very divergent amongst all of our patients. But I think that the most frequent thing we see as far as symptoms is just sort of weight loss and global loss of appetite and overall decreasing performance status without anything specifically being present.
Thank you. And what does it look like when you go in there for a surgery, because we hear a lot that it's not easily detected sometimes by scans. So when you do get in there, sort of how do you describe what the actual cancer looks like?
That's one of the most important things we do is to use a very early diagnostic laparoscopy in most of our patients to see what things look like. Often the omentum is obviously involved with tumor on the CT scan, and also and so we see a lot of ascites or fluid in the abdomen. But really the goal of doing a diagnostic laparoscopy is to look at the remainder of the organs, look at the peritoneal surface of the diaphragm, the abdominal wall, the lateral portions of the abdomen, but also the involvement of the stomach and the small intestine. Unlike a lot of other cancers, you can see a lot of sparing of normal organs in patients who have relatively significant disease. And there are some very subtle findings that experienced radiologists can see. But in general, we confirm those with diagnostic laparoscopy. Over the years, we have been much more aggressive in using MRI to help that. And I think that the use of an MRI is much more correlative with this degree of disease than a CT scan, but it can also be much more difficult to accomplish because it's a much more specific MRI. But we try and get it in the majority of our patients early in their diagnosis so we can use it long term to follow. We use it to follow response to therapy, especially in patients who undergo upfront therapy.
And in your sort of surgical procedure, what is it that you do for somebody that is diagnosed with peritoneal mesothelioma? Do you do the cytoreductive surgery? Do you do the HIPAC? What is your sort of standard of care?
So what we do and what we think is, unlike other types of cancer where we feel that you have to get all of the disease out in order to have the surgical therapy be effective, we know from a pretty extensive data set that very aggressive cytoreductive surgery is important, but also the intraperitoneal chemotherapy portions of the operation also appear to be very important. In general, peritoneal mesothelioma is a relatively chemosensitive disease. And what we see is that you can often get the vast majority of the tumor out surgically, but not all of it. And in times when removing all disease would be nearly impossible or would be associated with a lot of intestinal loss and a very dramatic change in the way people live their lives, we know that leaving a little bit of disease behind, less than 0.5 millimeter implants, and treating that with heated high-dose chemotherapy is a very effective strategy at disease control.
And when you put the high-dose chemotherapy in, this is a question I often get, how long do you leave it in for, and sort of what does that look like?
So everyone does this a little bit differently, and it's something that the group of physicians and surgeons who are doing this are trying to standardize. But in general, we use a drug called mitomycin C, and we put it in for 100 minutes, and it is circulated through the abdomen in a way that's agitated, so we get delivery to all the surface of the lining, and we give it in an elevated temperature, which helps the drug absorb. So at the end of that period, we wash out all the drug because we don't want it to continue to sit in there and slowly absorb. The two drugs that are most commonly used with this disease are platinum-based drugs such as cisplatin and mitomycin C. And the advantage of those drugs are that they stay predominantly in the peritoneal cavity and don't penetrate the bloodstream. But if you leave them in the peritoneal cavity for a long period of time, you will see their absorption start. And then you start getting off-target toxicity, especially kidneys and also bone marrow. But if we can keep them just in the lining of the peritoneal cavity, we found that the toxicity is quite manageable at doses that are very, very high and much higher than you can give people through the IV.
And sort of for you, what determines if a patient receives either only surgery or if they need chemotherapy or immunotherapy up front or after the surgical procedure?
That's a really difficult question to assess right now. And what I tell patients is that where we started and the data that we have the most long-term data on is that the cytoreductive component, or the removing of the tumor, and the intraperitoneal chemotherapy gives us about a 50% 5-year survivorship. And most of those patients do very, very well. If they're going to, on diagnostic laparoscopy, need a very extensive surgical resection, those are patients who we will now lean on upfront chemotherapy for. And that's a change over the last 10 years. I think the teaching when I first started doing this was that IV chemotherapy had no role. And I think that that's clearly not accurate, and that IV chemotherapy is very effective in this disease. And sort of figuring out which goes first and which goes second can be very difficult. And a lot of times, to be honest, it's the inability to control ascites that drives us to do the surgery first, because that allows the patient to actually have a better performance status to tolerate the IV chemotherapy. I think over the next 5 to 10 years, you're going to see immunotherapy used much earlier in this disease. But right now, it's been used in the post-operative setting or in patients who have recurrent disease. And really, we feel that IV chemotherapy, at least first-line IV chemo, is not effective. We try and do our best to tissue bank people and analyze the role of immunotherapy in all of our patients, so we can pick out the patients who are going to potentially do well with immunotherapy early on, because the high doses of chemotherapy can, especially for some of what we call adoptive immunotherapy approaches, can distort the patient's immune system and potentially have impact on immunotherapy down the line. So we try and pick our therapies thinking about what the next therapy is going to be as well.
Thank you. I would say that one of the biggest questions I get from patients is, if you have a patient who doesn't require systemic therapy, they were able to be surgically resected, considered NED, what is sort of the surveillance look like after that?
A lot of that depends on where they get surveilled and how much disease they had, but also what the availability of tumor markers. A lot of patients will have very good tumor markers, and so we can follow them for the first 2 years, every 3 to 4 months. We do a lot of MRIs. Here, it's harder to do the MRIs at outside institutions, not because of any quality issues, but because the protocols that have been developed on an MRI are very machine specific. And so in general, we use every 3 to 4 months with a CT scan, especially of the abdomen and pelvis, and tumor markers to follow people for the first 2 years, and then go to every 6 months for the next 3 years, and then yearly after that. We try to get an MRI once a year if we possibly can.
Okay. And as far as just backing up a little bit, but I get often asked as well, because of the tumor markers, I think people get a little bit confused, but diagnostically, in order to diagnose peritoneal mesothelioma, you do have to have a biopsy, correct?
Absolutely. Tumor markers can be helpful, but tumor markers are really not diagnostic of almost any malignancy. They certainly help direct therapies, but especially in the era of molecular diagnoses and potentially targeted therapies, you really want to look at the histology of the tumor, and also looking at some of the subsets of the histologies, looking at different types of mesothelioma to see who is, if you have a sarcomatoid component of your mesothelioma, especially if it's a high percentage of it, that's a much more aggressive tumor. And those are patients who we would almost invariably start on upfront systemic chemotherapy, regardless of tumor markers. So that's where the histology plays a very significant role.
Thank you. And as far as somebody being a surgical candidate, is there ever a time where they're diagnosed, maybe upfront they're not a surgical candidate, but they can become one with some sort of systemic therapy?
Absolutely. There are times in all cancers now that with very good chemotherapy regimens and very good supportive care that can happen. A lot of times the issue with mesothelioma and peritoneal malignancies in general, the issue is a nutritional one because of the insidious nature of this onset. And sometimes it's better to wait 3 to 4 weeks and put patients through an exercise and nutrition programs prior to doing anything, because these patients will get stronger with that once the sort of diagnosis and plan happens. and they can be stronger candidates for surgery. So jumping into anything to do it right away sometimes can give you more side effects than preparing the patient. And so there will be patients who come to us, unfortunately, especially post-COVID, where a lot of patients had difficulty getting access to care. You see things that got a little worse than you would maybe have seen pre-COVID, with better access to routine care. And so those are patients who do benefit from what we now call prehabilitation, instead of undergoing rehabilitation after the event, after chemo, after surgery. We actually do the rehabilitation beforehand to get the patient stronger. And it seems like, well, we're delaying care. But the reality of it is you get more therapy in if the patient is stronger and doesn't have delays or doesn't have post-operative complications. And so that little bit of focused effort preoperatively or even pre-systemic chemotherapy can be very helpful.
Yeah, absolutely. I know that one thing I recommend for people is afterwards trying to do some sort of like physical therapy or nutritional therapy because it's very helpful in the long run for their recovery process, for sure.
Absolutely. Both physical and mental. I think that
Yes.
it's very important, even preoperatively, to get people out and active. Everyone's always afraid of getting exposed or getting sick. And now that COVID is relatively under good control and hopefully most patients are vaccinated, I think we can safely push people to get out and about. And I think that not only does that help physically and nutritionally, but it also helps patients mentally.
Absolutely. As far as surgery goes with cytoreductive surgery and HIPEC, is there ever an instance where you will do maybe a second HIPEC or even, quite honestly, a third down the line if you have somebody that has recurrence of disease?
We have, and other centers have as well, and certainly that is really a reasonable option to do. A lot of that is based upon how much of a benefit we found the patient had the first time and what it would take to do the operation. Some patients can have very extensive surgery and have very minimal scar tissue and be amenable to a second surgery in a very straightforward fashion. And some patients, this second time around, can have a very hostile abdomen. It can be very difficult to just even get in. And that's one of the reasons why we aggressively try and bank tumors and do genetic typing of the tumors and look for immunotherapy markers, or immunotherapy targets, I should say, because the goal would be to not have to go back into patients unless we absolutely had to, either to re-site or reduce them or to get other therapies. But there's certainly patients of mine and other of my colleagues who we've gone in 5, 6, 7 years later and redone surgical therapy. So that's always an option.
And I know we had talked a little bit about this up front, but as far as telehealth visits, is that something that UPMC does offer?
Yes, and so we try to, I won't say limit the amount of travel, but really facilitate effective travel for patients. It's a relatively effective strategy for seeing patients, meeting patients, kind of getting the plan set up so that trips to Pittsburgh can be, or any hospital, can be very effective. It's often very much more comforting for patients to get an early appointment where we say, we're still waiting on X or Y, but here's the general plan we're looking at. Give us another 2 weeks to get things together, and then we can bring you here and talk about the comprehensive plan, rather than have patients leave the office with a whole laundry list of things that need to happen, and then have a lot of open-ended concerns and questions. I think for follow-up too, it's very important. Driving or flying in just to hear everything looks perfect, it's kind of a waste of resources and time for the patient. But also, if there are things going on, often seeing them by telemedicine can help you get things caught early, or not bring people in until you sort of have a plan as to what you can do. So we use it a lot for preoperative work, but also long-term follow-up with patients. And it's made it a lot easier for some of the patients with more rare diseases to follow them closely without it being too onerous on the patient.
Yeah, absolutely. And then as far as clinical trials, is there anything that you'd like to highlight that UPMC is offering either currently or in the works?
I think the biggest thing that's in the works are trying to figure out what is the absolute role of immunotherapy type regimens for patients with this disease. There's certainly for patients with pleural-based mesothelioma, there is ample evidence that some of the commercially available immunotherapy agents work well. And when we start to look at one of the things that we specialize in here with Dr. Uday Kamula, who's one of our basic scientist surgeons, is looking at the role of adoptive immunotherapy. So taking patients' tumors, harvesting the T cells out of those tumors and growing them up to make them react to your own tumor and giving them back to patients is something that's very encouraging, that we've seen very encouraging results. It's mesothelioma is one of those tumors that appears to have a relatively aggressive or interesting interaction with the immune system. So I do think that long term we're going to see that. Right now, because you have to get a relatively sizable piece of tumor in order to use those therapies, and it's not FDA approved, what we've done is tried to be very aggressive about harvesting these tumors at the time we do the operation, because then the therapies can be grown and frozen down for later use. And so we can do both things. We can do what we now know or what we feel is a standard of care for upfront therapy, get good control of the disease, but also have the potential second step in therapy ready to go for patients if and when they need it, and do them both at the same time. It serves the patient well because on a clinical trial, they don't have to pay for any of that. But more importantly, it also is one less surgical procedure for them to go through.
Yeah, absolutely. And that is that's the TIL trial that he is running,
Yes,
correct?
yes, absolutely.
Great. Yeah. That's a very exciting trial. I know that we've at least had a few patients that have been active with the foundation on it. So
Right. It's something that it's one of those tumor types that it definitely seems like there's very good activity there. And like every other therapy, the goal is going to be to find out who is going to respond well as best we can, but also what is the optimal time to use it. And so those are the questions that need to be answered. But I think it's progressing at a rate that it's a little more rapid than people initially thought it would.
yeah, and that is they do have to have an expression for that trial, correct?
Correct. And so that what you want to see is a sort of a twofold process. That number one, that we can actually grow T cells out of the patient's tumor. And then those T cells, even though they're in the location where the tumor is, not all of the T cells will react to that patient's tumor. And so that reactivity component needs to be present as well. And those are the two steps that happen before there's even any desire to freeze down the tumors and look at them for future use. Knowing what those targets are is part of what will happen moving forward. But really, you get a very good sense of patients who are potentially able to use this therapy.
And that's one of the things I think for patients to really think about is that this would be a next step. But in order to get ready for that next step, it does take some time for all those to be engineered and to go through all of the different testing that it has to go to.
Absolutely. And one of the things that we do worry about, we don't have a good answer for, but is, what is the role or what is the impact of high doses of intravenous chemotherapy on these T cells and tumors? When you look at some of the side effects of high dose chemotherapy, especially given systemically, one of the things you see is neutropenia or decreasing white cell counts. And since T cells are a type of white cell, we worry that if patients are very, very heavily treated prior to taking the tumor and trying to grow these cells, that you may see a level of toxicity to those cells, which prevents them from being applicable. And so it doesn't mean they shouldn't get other therapies, but it does mean we try and at least get the tissue and get the T cells so that if we need them down the line, we can have sort of run those tests and look at their activity and grown up those T cells prior to them getting a lot of other therapies, which may impact the health of those T cells.
Wonderful. Thank you so much. That's very helpful. It's a very exciting trial that you guys have going on there. And yeah, thank you so much for coming on today with us.
You're welcome.
Yeah, and I'd just like to highlight again, it's Dr. Pingpank. He's from UPMC, which is in Pittsburgh. If anybody is interested, please get in touch with me or get in touch with him. And absolutely, thank you for being with us today.
Thank you for your time, and thank you for all your support.